I'm pleased to introduce CAPEC Associate Member Congresswoman Lucy McBath. Congresswoman McBath represented Georgia's 6th Congressional District from 2019 to 2023 and has since represented the neighboring 7th District since 2023. Congresswoman McBath works to ensure all Americans have access to quality, affordable health care, and she partnered with Senator Warnock to introduce a bill that would cap insulin costs at $35 a month for seniors on Medicare. Congresswoman McBath has also introduced legislation requiring Medicare to cover hearing aids, and her bill was included in the Lower Drug Costs Now Act. Let's give a warm APAICS welcome to Congresswoman McBath.
Hi, my name is Congresswoman Lucy McBath, and I represent the Metro Atlanta area in the United States House of Representatives. I am so pleased to introduce today's panel. I am proud to represent a district that many Asian American, Native Hawaiian, and Pacific Islander constituents call home. Our community is a rich tapestry of ethnicities, nationalities, of faith traditions, and of experiences. We see this reflected in our classrooms, in our places of worship, and in local businesses. As their representative and a member of the Congressional Asian Pacific American Caucus, I celebrate this cultural diversity and work hard in Congress to champion policies which ensure that Asian Americans are supported and well represented in our federal government. Since coming to Congress in 2019, I have been a strong advocate for improving health outcomes in Georgia, and I am grateful for the opportunity to send my greetings to you today. Today's panel will focus on the social determinants of health for Asian Americans, Native Hawaiians, and Pacific Islanders. As our panelists will share, the foundation of a life must be strong before one can dream of excelling. A foundation of nutritious food, clean water, safe shelter, access to education, job opportunities, and agency in one's own life. It is only then that we can support our communities and set our neighbors up for the success we all know is possible. As leaders in your respective communities, I hope today's discussion can serve as a productive dialogue that will translate into meaningful results for the people that we are called to serve. I also want to thank the Board of Directors of the Asian Pacific American Institute for Congressional Studies once again for inviting me to introduce today's panel. Please know that I'm here for you in Congress. I look forward to working with you, fellow advocates, doctors, patients, and healthcare providers to improve health outcomes. Thank you for being here today.
Welcome back to the 2024 APAICS Health Summit. I'm Madeline Milka, President and CEO of APAICS. Our next panel is Beyond Healthcare, Unraveling Social Determinants of Health for AA and HPIs. The basic necessities of life, food, shelter, transportation, physical safety, participation in decision-making, education, and job opportunities are prerequisites for health. These factors are often described as social determinants of health, defined by the U.S. Center for Disease and Control Prevention as conditions and places where people live, learn, work, and play that affect a wide range of health quality of life risks and outcomes. This panel explores the social determinants of health that profoundly influence the well-being of AA and NHPIs, including diet and culture, housing, and education, and how these factors affect the overall health of these communities, including mental health. Experts on this panel will address these unique social, economic, and environmental factors to find opportunities to advance health equity for AA and NHPI communities. Our moderator for this session is Adrian Bacong, a postdoctoral research scholar at the Center for Asian Health Research and Education within the Stanford University School of Medicine, Division of Cardiovascular Medicine. Dr. Bacong is also a current postdoctoral scholar in the Division of Endocrinology at the Stanford University School of Medicine and is a postdoctoral affiliate at the Center for Innovation in Global Health. Dr. Bacong's current projects evaluate the utility of racial correction factors and cardiovascular risk algorithms. His research also explores the intersections of immigration and structural racism on health, specifically among Asian individuals. Let's give them a warm welcome.
Well, thank you so much again for the kind introductions. Again, my name is Dr. Adrian Bacong. I'm a current postdoctoral scholar here at the Stanford University School of Medicine in the Department of Medicine and the Division of Cardiovascular Medicine. And today we have a very wonderful and esteemed panel who will share with us this idea of social determinants of health and think about how we can think about social determinants of health in the context of government and in the context of health and the context of policy. So to start things off, what I would like for all of our panelists to do is to first introduce yourselves and answer this question for me. How would you define the social determinants of health? And let's go ahead and start with Dr. Yanghee Wu.
Hi, Dr. Bacong. Thank you so much. My name is Yanghee Wu. I'm an associate professor of surgery. I'm actually a gastric cancer surgeon at City of Hope. I'm also the vice chair of international affairs and the policy lead for the Gastric Cancer Disparities Initiative, which I represent today.
Wonderful, Dr. Wu. And could you answer the question for me? How would you define the social determinants of health?
I think we should take the WHO Commission on Social Determinants of Health definition. They define it as social determinants of health as conditions in which people are born, grow, and live, work, and age. In the context of the Asian American community and cancer, in which the field I work, social determinants of health I think of as non-genetic factors that affect a person's or subpopulation's predisposition to cancer, access to cancer care, the type of cancer care that they receive or we receive, and an individual's or community's cancer care outcomes. So they're all intermixed. One example specific to a multicultural nation such as US would be different places of birth, immigration status, and cultural differences like language that affect the person's cancer perspective.
Wonderful. Thank you, Dr. Wu. Now I'd like to introduce Dr. Michele Wong. Dr. Michele Wong.
Hi, yes. I am a current postdoctoral scholar at the Initiative to Study Hate, and my sort of background is kind of at the intersection of sort of social welfare and public health. And my work really kind of focuses on thinking about the workplace, and certainly with the Asian American women population. And so when I think about social determinants of health, I think a lot about oftentimes many of us spend many hours of our day within a workplace. And so that can certainly structure your health outcomes really via your income benefits, could be certain exposures to workplace hazards, but also really thinking about how your own identity and sort of the intersections of your identity can interact with your environment, in this case, certainly the workplace. And I think, yeah, that was social determinants of health. And was there, sorry, another question to that too?
No, thank you so much again, Dr. Wong. I'd like to go to Dr. James Huynh. Dr. Huynh.
Hi, everyone. Thanks so much for having me here. So I am a current doctoral candidate, so not quite a doctor yet, at UCLA in the Department of Community Health Sciences. But I am an incoming assistant professor in the Department of Health Management and Policy at the University of Michigan, where I'll be focusing on anti-racist health policy work. And so I consider myself an interdisciplinary community health scientist, and my work seeks to dismantle the root causes of health inequities, namely racial capitalism, patriarchy, and heterosexism, by examining the health of LGBTQ, so lesbian, gay, bisexual, transgender, and queer Asian American social movements. And in particular, when I think about social determinants of health, I think about not just, as Dr. Wu mentioned, where people work, live, play, and pray, but also how LGBT Asian American communities cultivate their own cultures of health and how they actively engage in changing their environments through politics, whether that's big P electoral politics or small p personal politics that feminist movements have taught us. And to really think of social determinants as also social movements and activism in changing our environmental context. Thanks.
Wonderful. Well, thank you so much, James. And finally, and last but not least, Dr. Hing.
Thank you, Adrian. My name is Anna Hing, and I am a research scientist at the University of Minnesota in their Center for Anti-Racism Research for Health Equity. And my work there is on structural racism. And so when I'm thinking about structural racism, I'm often thinking about voter suppression as one form of structural racism and something that upholds white supremacy within our systems, and also as a way that we stratify power. So as James was talking about power in politics as well, that definitely comes into my work, and really trying to think about how those social processes stratify power, and then how those inequities in power lead to inequities in health. And so when I'm thinking about social determinants of health, I'm really thinking about how these are patterned across society because of these hierarchies of racism and capitalism, and then how power and politics come into play. So how are people able to use the power that they have, either through voting or other means that James was talking about, to change the resources and change their social determinants and act on that either as an individual or from a community perspective. Yeah.
Great. Well, thank you so much, Dr. Hing. So it sounds like in terms of this idea of social determinants of health, we have this traditional definition that Dr. Wu shared, where we're looking at the places where people play, pray, and stay. And I think with respect to what you've all added on, future Dr. Huynh, if I may refer to you as that, this idea of community. Dr. Wong, you added this idea of environment. Dr. Hing, you added this idea of power. And I kind of want to ask a little bit of clarifying questions in terms of this. So, Doctor, will you bring up this idea about thinking about culture as a potential social determinant of health? Could you clarify a little bit to me what you mean by culture, and how can we think about culture as one of these large factors that affects health?
Sure. So culture, I think of culture, and in the Asian American community, we have so many different languages and places of birth, different generations. So I'm a 1.5 generation. Many of us, my colleagues and friends were born here. Some of us are third generation. So the history of culture has evolved from the origins of where maybe our grandparents or our great-grandparents came from. And they brought that all into in an American mixed culture, assimilation versus integration, those kind of ideas. Also the language. I think culture is defined a lot by language, and sometimes language becomes barriers to access to cancer care or health care. And we know that it could also be barriers to a disparity in the cancer can occur because some of our culture, and if you think about the foods we eat, where we live, we congregate towards living in in urban areas. Many Asian American communities are in LA, in New York, and East and West Coast, and they're maybe very distinct from cultural interactions that occur in other areas of the country where there's an increasing Asian American population. So I think it becomes very heterogeneous amongst the Asian Americans. So we can't, I want to highlight the importance of disaggregated data and understanding the subpopulations of Asians and the different cultures, the languages, the foods that we eat, and interaction within the community that we have, specifically as it relates to cancer care outcomes and incidences.
Wonderful. Well, thank you so much for clarifying this idea of culture for us, Dr. Wu. So Dr. Wong, I think related to this idea of culture, and what Dr. Wu is highlighting a lot about is this idea of environment, about places we live. But I think for you, Dr. Wong, you focus a lot on the idea of work environments. So could you clarify for us, what do you mean by environment as a social determinant of health? And what can we think about with respect to environment as well?
Sure. As far as environment, I often think about organizational structures that Asian American women are working in. And so, for example, within the STEM workplace, organizations certainly have particular hierarchies, and often those can be racialized. And so when I think about how structures can then kind of dictate, how much agency an Asian American woman has to make decisions in the workplace or have certain access to resources. There are various factors that can certainly impact how they are able to gain sort of mobility as well. So to me, it's this sort of interaction between both, hiring and promotion practices, for example, that can also structure their ability to advance throughout their career. And so I was also kind of thinking more about what Dr. Wu was saying as far as culture too, where these, I guess, differences that we see across, various groups and certainly within Asian American women can also kind of develop into cultural stereotypes or, certain ways in which maybe work ethic is seen to manifest in particular way where, say, model minority myth stereotypes actually are perceived or kind of like experiences of workers saying that their supervisor expected them to just kind of take on more work because they were deemed to be hard workers, and so that can also certainly interact with workplace environments and certainly how supervisors and managers structure sort of workplaces and certainly hiring practices. So there are various aspects between sort of individual and environment.
Great. Well, thank you so much, Dr. Wong. And I think you hit on something really interesting about the ways in which our environments or our perceived environments, how it shapes how we treat other individuals. Thinking about how we treat other individuals, future Dr. Huynh, or James rather, I want to think about a little bit this idea about community. So a lot of the work that you focus on is this idea of community or found community, especially among LGBTQ plus individuals. Can you define for us this idea of community and how does that relate to our ideas of social determinants of health?
Yeah, I think the idea of community is really complex. I think most often we think of community as having some shared identity or affinities. So thinking about we're having a summit on Asian American, Native Hawaiian, Pacific Islander healthcare. And so that can be a kind of community, like along those racial lines. But then we can also think of community being built along other things like political values or gender, sexuality, or really just anything that cultivates a kind of sense of belonging, meaning. And so in my work on LGBTQ Asian Americans, specifically Vietnamese Americans in Southern California, I've been studying and collaborating with an organization called Viet Rainbow Orange County, or VROC for short, and how they formed their own sense of chosen family by building intimate connections with people who aren't necessarily their biological kin, but we'll call them family regardless. And so really thinking through how can different sources of social support and belonging provide people with a sense of purpose and a sense of feeling like they are part of something larger than themselves, that they can then contribute to and help out with. And so I think about how those things help marginalized people in particular survive amidst political and social climates that are trying to enact like everyday racial homophobic violence against them.
Thank you, James. And then finally for Dr. Hing, we talked a little bit about this idea of culture. We've talked a little bit about these ideas of environment and of community. But at the end of the day, if we think about this, the role of social determinants of health, or rather social factors that ultimately affect health, something that I was really struck by with your introduction, Dr. Hing, was this idea of power. So could you clarify what you mean by power and ultimately help us make the link between how do social factors ultimately affect our health outcomes through this idea of power?
Thank you, Adrian. So I think to start, we'll just get into that definition of power. And so I think, right, a lot of us come from social science backgrounds, and we know that power is actually can be a really complex topic, and like anthropology and sociology, we've thought through this. But I really appreciate this definition from Alicia Garza, who was one of the co-collaborators and initial members of Black Lives Matters, and she defines power as the ability to change your circumstances and the circumstances of other people. And so I think this is really simple, and it really calls us to think about what is your ability, your agency, the autonomy that you have as an individual, and how can you use that to enact changes within your environment on those social determinants of health, and then also in a way that helps your community, your family members, right, people around you, from a very local level all the way up to the state and national level. And so when we're thinking about making this connection then between power and social determinants, I think, as I said a little bit before, we're trying to think about how those social determinants are patterned across society, and they are patterned differently, right? Like we know that certain groups of people are more likely to be exposed to poor social determinants of health, such as toxins in their water and environment and neighborhood and different things. And that's not happenstance, right? That happens from policy decisions. And so you all, as a member of staffers and politicians on this call today, you understand how that works, right? And so I think one of the key forms of power that is most connected to your work is voting. And I think that's how in the United States, a lot of how we think about people can make their voices heard in that very concrete way. And so when people show up to the polls to vote and have power over the laws and policies that shape the social determinants in which they live, that's what they're trying to do, is to use that voice in order to make a change that will benefit them and their health and those social determinants.
Great. Well, thank you so much for sharing this idea and these connections, Dr. Hing, about how power, how these social ideas influence our ability to make decisions that ultimately will help to benefit our health. So I wanted to try to come back to this idea of health and thinking about these ideas of the heterogeneity of social determinants within the Asian American community. And I want to first start with James. So thinking about these ideas of social determinants of health, what are some key social determinants of health in your work that we should be mindful of, especially with the working in the communities that we work with?
Yeah, so I'll speak specifically to Southern California, maybe not even just Southern, but thinking about Vietnamese Americans and particularly LGBT Vietnamese Americans. Two things that I'll touch on. One, Vietnamese Americans have a very specific history of migration to the US, stemming from the war in Southeast Asia in the 60s and 70s. And so cohorts of refugees from that war came to the US. And so trauma from wartime and from military intervention in Southeast Asia has affected certain kinds of refugees that come to the US, whether that's, and it's very heterogeneous as well. Like the first cohort of refugees were more wealthy, connected politically people. And then later cohorts tended to be people fleeing out of like economic and political persecution. And so that, in thinking about the diaspora in the US, Vietnamese communities have a deep history of intergenerational trauma that then manifests as various political divisions within the community, thinking about anti-communist Vietnamese, diasporic people, and then more emerging progressive leftist folks. And that doesn't necessarily fall along generational differences, which I think people tend to think of like, oh, older people tend to be more conservative, and then younger people tend to be more liberal. And through my work with Viet Ream of Orange County, I found that there are older people who are very progressive, very inclusive of LGBT people. And so I really want to debunk that generational political difference myth. The second thing I'll touch on, which is I think very relevant to today's political climate, is the rise of anti-trans legislation throughout the country. And in particular in California, you know, people often think of California as a very liberal state, but there are many school districts in California that are passing what are called parent notification policies, which basically would turn school personnel into essentially mandated reporters of if a student were to like start using a different pronoun or start identifying as a different gender, then school personnel would be mandated to report that to their parents. So forcibly outing trans, non-binary, gender non-conforming kids to their parents before they want to have their own agency to come out on their own. And so advocates on the ground are fighting against this in different school districts. And so thinking about the intersection between Vietnamese and trans and queerness is dealing with how do you have those difficult conversations with refugee families across language barriers, across trauma, and then how do people advocate for that on a larger scale than outside their families and through their cities and school districts. So those are specific things that I think about.
Well, thank you so much, James, for sharing a lot of these ideas about thinking about, there's the aspect of history that we need to think about the historical context in which certain groups are here, but also in light of some of the legislation that comes out, in light of the changing social movements that are going on as well. Dr. Wu, I'd like to come back to you in terms of thinking about this idea of the importance of social determinants of health. So what I'd like to ask for you, Dr. Wu, are, with respect to you as a clinician, what are some key social determinants of health that we should be mindful when working with communities, especially in your context with working with people who have cancer?
So thank you for that question, actually. There was a paper that was published talking about the model minority, Asian Americans, and NHPI communities being seen as a model minority. So in cancer, when we talk about model minorities, we think of if you look at the population as a whole, then we're better educated. We have higher socioeconomic status with presumed better access to cancer care. But if you look at the subcommunities going back to the importance of understanding the subcommunities that differ in socioeconomic status. These are social determinants of cancer health and outcomes. We know that lower socioeconomic status is associated with, poor, more advanced stages of cancer diagnosis and poor outcomes. If we live far away from tertiary cancer centers, that outcome is also poorer. And so if we look at within the Asian American and HPI communities, we want to make sure to tease out these specific social determinants of cancer outcomes, like socioeconomic status, like access to fresh fruits and vegetables. We talk about food deserts, that's been in literature quite a bit. And to understand specifically the subpopulations that are more adversely affected. I'll give you an example for gastric cancer with the Gastric Cancer Disparities Initiative. We are looking at patient populations that are more adversely affected. For instance, gastric cancer incidence is highest in the Korean American community. That's my community of Korean Americans, highest incidence, but the best outcomes are there too because of increased awareness and advocacy that has occurred in the community and early endoscopy screening that has been done, even though the national guidelines do not include gastric cancer as a screening disease. Among Americans, our recent research in the California Cancer Registry have found to have the worst outcome. Right. So you can't lump all Asian Americans and HPI community together to make policies. Right. So whatever we determine is adversely affecting cancer outcomes and incidence has to be looked at very distinctly within the subpopulations of Asians and where we live. The highest incidence of gastric cancer occur in California, Hawaii, New York, New Jersey. These are places where ethnic minorities, not just Asian Americans, but Hispanic Americans, the Latinx community are living, African Americans. So I think it's imperative for us to really look at the disaggregated data and push for research in areas, not for all Asians like lumped together, but to be able to really tease out the subtleties within our communities so that policies can be directed to help specific populations at risk or with poor outcomes in cancer.
Thank you, Dr. Wu. Really well said. And I think to think about the parallels between what James said and you said, I think it's really this importance of contextualizing the different disaggregated Asian ethnic communities as well as Native Hawaiian Pacific Islander communities. And I think I want to kind of come back to this idea of contextualization, specifically with a focus for you, Dr. Wong. So for your work, you mentioned that some of your work is among Asian American women. How does this idea of contextualizing workplace environments for Asian American women matter for your work and social determinants of health?
Sure. I think a lot about specifically for Asian American women experiences of gendered racism. And so that is sort of like the intersection that I explore where, racism and sexism do have unique experiences for Asian American women. And in this, I mean, ways in which certain aspects of being seen as submissive or kind of being assumed that, all Asians kind of have the same appearance. So being, easily mistaken for another coworker. And so and then certainly there's aspects of the sort of sexual fetishization. So these all kind of play a part in this experience of gendered racism, which I, see as a intersectional stressor that is unique amongst Asian American women and can certainly play out differently for different Asian American women based on their context. And this is something that I guess I'm much more focused on as far as perceptions that can also be shaped by other cultural stereotypes. And so I think we also mentioned, how model minority myth might be at play and how that might also intersect with gendered racism experiences. And so this is something, I guess, as far as exploring other kind of implications too, that, when we think a lot about diversity, equity, inclusion efforts, and a lot of which I believe are kind of under attack right now, that, these can look different for different populations. And so for Asian American women in particular, there's a lot of research that shows many of them are never sort of seen in sort of leadership roles. And so many times, having equal education, skills, training, that they still aren't able to advance to sort of higher levels. And so if we think about designing diversity, equity, inclusion policies as well as practices, does that sort of fit the unique needs amongst Asian American women? And so this, I think, also needs to be kind of taken critically as far as like how certain efforts like these can also be used to kind of maintain, I guess, status quo within any organization. Kind of going back to, again, thinking about organizations being racialized as well. So are organizations making a commitment to these sort of efforts? Are their practices actually following through? And so, thinking about potential audits or sort of practices that can ensure that that's actually happening within different organizations. But certainly there are a lot of hurdles and it requires a lot of resources. So thinking about, where does that funding go as far as allocating, again, resources to particular groups within workplaces and how, again, their identities are certainly coming into play and intersecting with their context.
Great. Thank you so much, Dr. Wong, for sharing a lot of that. So again, so far we've heard this idea of tailored interventions, really understanding community, really understanding the context and the history. And Dr. Hing, I want to see if we can summarize this up together. But again, our focus when we think about policy is not so much just to benefit the Asian American Pacific Islander community, but it's ultimately to try to benefit all communities. So thinking about this idea, and oftentimes we think about coalitions or cohorts among racial lines, how can we think about policies to strive for, specifically for the Asian American community, that could benefit other communities as well?
Thanks, Adrian. So yes, thinking about voting, right? We're not really thinking about one specific social determinant of health, but we're thinking about voting as this mechanism for people to exert agency and power over those social determinants and to try to shape the world that they want to live in so that it benefits them. And so when we're thinking about even the history of voting within the United States, we can't really understand that in a vacuum as well. And so, right, when the United States was founded, it was founded with voting as a right only for white men. And then we saw that that vote was expanded for people who then did not own land, right? And we saw it based on class and then race and gender. But even when the right to vote was expanded in throughout the 1800s after Reconstruction and then through the 1960s, right, that right to vote was always contested for certain racial groups. And it was never really truly protected in the way that we had hoped, right? People who were mostly for Black people, right? It was going to the polls to vote and facing direct forms of violence, poll taxes, literacy tests. And those things were to target Black voters, but they also influence Asian voters and other immigrant or group voters as well, Latino voters, right? People who don't speak English. And so things such as that. And so we can see how these laws are all connected. And so whether they're targeting Asian American voters specifically or Black voters specifically, they all have the influence to disenfranchise anyone who is not kind of that and that's not even the majority of the United States anymore, but who the United States was built for, right? Those along white lines of whiteness and white supremacy. And so when we're thinking about then a major determinant of social determinants, I guess is how we're thinking about it, we should really be concerned about these laws of voter suppression that we're seeing spike up again. So right in 1965, the Voting Rights Act was passed, and that really protected voting rights for a lot of people. But then in 2013, we saw the Shelby County v. Holder Supreme Court Act. And what this did was invalidate part of the Voting Rights Act. And it made it really easy to start pushing for these voter suppression laws, whether that was requiring identification to be shown at polling places or making cuts to mail-in voting and other things such as that. And so we can see that those not only hurt Black voters, but Asian voters as well. One of the groups that it's most likely to vote by mail is Asian voters. And so we can see then that if we're allowing these voter suppression practices come in, they hurt everybody. And so in trying to think about how we can advocate for different laws and policies that not only help Asian Americans, but everyone as a whole, we need to be thinking about how these struggles against white supremacy and racism are connected, and how can we bring those together to move towards health equity.
Thank you, Dr. Hing, and thank you for highlighting this idea of how the policies we implement not only affect our, Asian Americans and Pacific Islander individuals, but they affect all individuals, regardless of race. And so we have to really think deeply as to what are the particular issues that we see. And so I want to come back to this idea of policies, thinking about policies that we should advocate for, but also thinking about what are some of these challenges that affect our policies. So perhaps we could start with Dr. Wu. What are some of the policies that you in your position would advocate for, but what are some of the challenges that you also face in advocating for these policies as well?
Yes, that's a really good question. We've been advocating for the Gastric Cancer Disparities Initiative and the Social Determinants of Health Work Group have identified certain areas, and specifically, we look to disease specific for cancer policies that it will help patients in a very specific disease process like gastric, lung, or breast within the Asian American community. And so talking about gastric cancer is one disease that does not have a screening guideline, even though it's an increased risk and there's a disparity that affects specifically Asian Americans. But talking about, increasing on influence and collaborating with partners, this also affects the Hispanic American community at large and young Hispanic men, who have the incidence of increasing rates of gastric cancer in the community. That is very notable in California. So in terms of policies, we would love to see, both the Gastric Cancer Disparities Initiative and our Social Determinants Health Work Group in the U.S. and at City of Hope and collaborators across the U.S. would love to see a screening guideline, first for prevention and H. pylori to prevent gastric cancer, and also endoscopic screening for high-risk populations. This is something that we had sent to the ASPSTF for review, and it was rejected. So there are some specific disease-specific guidelines, and also to work across partnerships with people. I mean, the experts on this panel are like across different disciplines, and to come to have webinars like this and discuss topics and have like talking about Dr. Hing talking about power, can we impact change alone? Probably it's very difficult. Some of the challenges is that some of these interest groups or the areas that we advocate for are of small populations within populations, right? Looking at gastric cancer, it's a low incidence cancer in the US, but cancer, it happens to be the leading cause of death in Asian Americans, unlike the rest of the country. So the rest of the other ethnic groups or minority groups. So I think joining, one of the challenges that it's a very low, it's a small group. There's many small interests. And in order for us to have significant impact, we have to join forces across disease, disease specifics and across disciplines. I think to have more influence and power and have policies that actually help all of us, but understanding how they would help us. So resources are of of great lacking, I think, funding for the research for this and developing programs that would help, eliminate some of these disparities in care. So I think it would be very beneficial if we all work together to tease out the most urgent areas of need and partner together to make policies that would affect many of us.
Thank you, Dr. Wu. So I'd like to go to Dr. Wong next. So Dr. Wong, you've highlighted some of these ideas of diversity, equity, and inclusion policies as a way to try to increase leadership, for example, among Asian American women. But what are some of the challenges that you anticipate in terms of efforts related to diversity, equity, inclusion?
Sure. I certainly am thinking a lot about actually a conversation I had with another sort of head of human resources and some of the challenges that they faced in implementing diversity, equity, inclusion programs. And I think that right now they're sort of at a point where certainly doing implicit bias trainings and trying to facilitate more discussion, really critical dialogue between different workers is sort of the first step. But I think that major challenges certainly fall around gaining the resources and funding to actually implement these programs within a workplace. And then on top of that, really trying to focus on specific identity-based issues. I think that can be a big barrier to kind of focus on each individual experience, because certainly, although I would, appreciate having trainings focused on gender racism, we might be kind of far from there at this point. And so thinking about other ways that trainings that can engage more, diverse groups in dialogue to kind of talk about the ways in which certain stereotypes or certain ways in which these are kind of coming up and manifesting for different individuals. So this, could be done through special interest groups. And so maybe that is a potential for Asian American women to have a place to discuss these sorts of experiences, and that being kind of leveraged further into their, organization or people that have the power to ensure that they're receiving funding that they need and sort of resources. But, I was also even thinking about other ways in which hiring and promotion practices could be more transparent across the board, as far as making sure that that is, I guess, clear to all employees, and is also something that is, maybe either further audited or just kind of investigated as making sure that that's actually being implemented, I guess, in the workplace. And another thing I guess I feel like would be helpful as well is thinking about aspects of work-life balance, which I think, can really benefit so many people within the workplace, because for Asian American women in particular, if they're also taking on, additional responsibilities around like caretaking, but then at the same time dealing with these challenges of having to take on more because, maybe they're being seen as being very submissive, or they're kind of seen as having a high work ethic, that this will be difficult for them to maybe navigate within the workplace along with other responsibilities outside of work. So how can we think about more flexible work arrangements, certainly around parental leave, and also offering more affordable childcare? So, these are things that I think certainly anyone would really benefit from, but thinking about the ways in which within the workplace, things are certainly racialized, but also gendered too. So I think there are many areas within the workplace that could benefit from these different policies.
Thank you, Dr. Wong. And again, I think what I really like about your response is you're highlighting some of these common things that we think would be, not just specific to the Asian American Pacific Islander community, but specific to all communities as well. I'd like to now shift to James. So you've talked a little bit about some of the challenges with respect to anti-LGBTQ plus legislation. But what are some other challenges that are kind of unseen with respect to this idea of promoting the health of LGBTQ plus people, and also LGBTQ plus Asian American Pacific Islander individuals?
Yeah, thanks for that question. One thing I've been thinking through a lot is we have quite a number of older queer Vietnamese people in the organization that I work with, and they've been like talking about like how to age in place in like a culturally relevant way, but also how how can they age and be supported by the people that they love? And a lot of times their loved ones are non-biological kin. And so when we think of healthcare policy, a lot of like medical care policy, like when you have to go to the hospital and see someone, it's usually a next of kin policy, and kin is defined very narrowly, you know, whether it's along biological lines or legal lines. Um, and so long-term services and supportive in-home support services are a type of policy that, or a type of like area that can provide um, leeway for like chosen kinship to be a model for aging policies and care policies. And so Medicaid has an institutional bias that favors long-term services in nursing homes rather than supporting in-home services where people can choose their caregivers. And by choosing caregivers, they can choose, you know, whoever their loved ones are. And so in that way, it's not just for queer Asian Americans, but just for any aging adult who like might have fraught relationships with their biological family, and they can choose other people to care for them instead. So that's a kind of challenge, but also a next area of work that I think could be really worked on and relevant to you know, the staffers who are on this call today.
Thank you so much, James. So Dr. Hing, I'd like to kind of close out like our discussion about challenges with you. What are some of the challenges that you anticipate in terms of policies related to Asian Americans, Pacific Islanders, but also just general populations as well?
Yes, I think one of the biggest challenges just around voting in general is that we're seeing these pushes for voter suppression laws. And so I think like that's something that we all need to be really cognizant of and really trying to fight against. But I think we also need to be thinking about more generally, not only how these policies do influence us all. And so by passing mail-in voting and like protecting that helps everyone who's trying to vote who may not be able to access the polls because of disabilities or other things as well. But I think like for the Asian American community too, we need to be thinking about how sometimes policies that we pass that are specifically to help us can actually do harm to other communities. And so I think one of the biggest challenges that the Asian American community has faced in the past couple of years has been the COVID-19 pandemic, right? And there was a rise of anti-Asian hate that followed that. And it was really scary for our community, right? We saw an increase in violence. But I think when we looked at the solutions that were put forth, a lot of these came from very like carceral and like were grounded in policing, right? And so the solution was to arm police to arrest more people for these hate crimes, but not really interrogating what was driving these. And I think Dr. Wong also does a lot of research on hate and could probably talk about that a little more, but I won't put her on the spot. But in thinking about why those policies were put forth and what they did, they really highlighted that like in order to protect ourselves, we were using structures that actually do a lot of harm, that are grounded in anti-Black racism and that perpetuate systems that we know harm Black and Latino and Native populations as well. And so I think like as we're trying to think forward in terms of what policies can best help Asian Americans, I think we need to be doing this from a really critical perspective that interrogates how racism might be operating to harm other racialized groups, and then how we can think about kind of like raising everyone up together and centering all of these like racial capitalism and different structures that harm us all, but in different ways because of these different lineages that we have within the United States.
Thank you so much, Dr. Hing. So I think we're getting near time, but I'd like to kind of provide some summary points. So we first started with defining social determinants of health, thinking about how social factors influences our power in order to make decisions that ultimately can help us. We've also highlighted some of the work with respect to you all in terms of how does your work ultimately influence not only Asian American communities, Pacific Islander communities, but also just the general broad communities. And I think one of the key things that I've taken away from this conversation is the importance of thinking not only of our policies as supporting Asian American Pacific Islander communities, but also doing it in partnership with other groups. Thinking about how can we get the maximum benefit for our groups. And Dr. Hing, I really want to kind of end with your point is that thinking about in a critical way, how can we think about our policies in a way that while it might lift certain groups up, it doesn't push other groups down. So I think with that, I want to thank you all for your time again. I want to thank all the staffers and everyone who's on this call as well. Thank you all again, and please feel free to reach out to us if you all have any questions, whether it's about the work that we do or how we can partner with you all in terms of creating policies that will benefit everyone. Thank you.
Thank you so much. This is so informative. I learned a lot from all of you.
What a great day we've had together. I hope you've learned as much as I have from our amazing panelists and speakers. I'd like to recognize our summit partners, Amgen, Cencora, Biogen, Bristol Myers Squibb, Pharma, Walgreens, Planned Parenthood, Catholic Health Association of the United States, GlaxoSmithKline, and Otsuka, as well as all of our panelists, moderators, and partners. Your support enables APAICS to fulfill its mission of promoting Asian American, Native Hawaiian, and Pacific American participation and representation at all levels of the political process, from community service to elected office. Please visit www.apaics.org to learn more about our work, and I look forward to seeing you the next time.